Are you scared or anxious about the state of bodily autonomy? Do you want to get involved in the fight? I'm Jenny Wetter, and I host the podcast Repros Fight Back. Each episode, I interview a guest about a specific topic across a wide range of issues, from abortion access, to birth control, to LGBTQ rights, to abortion, to gender-based violence, to Project 2025, and did I mention abortion? We talk about what is happening around that topic and how you can get involved and fight back. If that sounds like your jam, make sure to check out Repros Fight Back on your favorite podcast platform.
Support for The Nocturnist comes from the California Medical Association.
At The Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
The nurse transfers the call to me, and I find myself in a video call with a delightful 80-year-old patient who's had a head injury.
This is The Nocturnist, Uncertainty in Medicine.
I ask him, I say, what were the circumstances? He says, well, doc, I've got this wound on my head. I got it working in my garden. I kind of tipped over, fell forward, and hit my head on a rock. And it bled a lot. Can you just send a nurse here? I say, hold on a second. Have you looked at it? What does it look like? And he says, I don't really know. I don't know how big it is. I just know it bled. I say, have you tried to look at it with a mirror? He hadn't done that. He said, great idea, though. So we try to examine the wound using the camera on his phone, and I get kind of this shaky image. It's far too close up. I can't tell what I'm looking at, and it looks kind of bad, actually. So I say, look, I really need to look at this wound. You're going to have to take a picture and share your screen with me. So he figures out how to share his screen, and I gasp because the wound looks terrible. It's covered in pus. There's blood trickling down. He says, no, I put antibiotic ointment on it. So I say, okay, well, we are going to wash that off. Oh, no, we're not, because then it's going to bleed. And I said, look, I'm there with you. We're going to wash it off together, and we're going to see what's underneath so that I can give you some guidance.
This is Jenny. She's been a tele-emergency doctor for years and says that sometimes it's hard to tell whether the uncertainty she's experiencing comes from the medicine itself or the fact that she's delivering it through a screen.
Reluctantly, he takes me with him through this kind of cabin in the Santa Cruz mountains somewhere. He finds a clean washcloth and he says, well, what do I wash it with? Alcohol? And I say, no, just, warm, soapy water. So he proceeds to do that. And he's relieved because he says, it's not bleeding. It doesn't hurt. So I ask him to then take an after picture, and he does. And he shares his screen again, and the wound looks fine. It is a superficial wound. Everything's great. And he says, Doc, this is great. I'm fine. Thank you so much for your time. Bye-bye. I say, no, not so fast. We're not done. Remember what the nurse said to you. She said she wanted you to go to the emergency room for a CAT scan of your head. And he says, I'm not getting a CAT scan of my head. I don't need that. I am fine. I don't even have a headache. So I say, look, you might be okay, but I really don't know that for sure. And I'm not going to be there with you when you get a head bleed and die. He says, I'm not going to die. I'm fine. I feel just fine. And proceeds to kind of dismiss me, which is easy for him to do because he can just hang up. But he was very sweet and he said, you've provided me a great service. Time to go. I let him go. And of course, I fret about him for the next 3 days, chart stalking him to make sure he's still alive. And he's just fine. I noticed that he made a call the following day asking for a refill of medication. So really, he was fine with the situation that made me definitely uncomfortable, but he got what he needed, which was wound care, which was really all that he was looking for.
Communication. It's central to medicine and one of its biggest challenges. There's no formula for how we relate to each other. It plays out differently in every scenario. Take Jenny, for example. She said this story is pretty typical of what she experiences as a telemedicine doctor. Uncertainty is part of every encounter. Sometimes she's the one who's more comfortable with it. Sometimes the patient is more willing to accept the unknown. But either way, she has to work within the limits of delivering care through a screen. Today, we're exploring the gray space where medicine meets relationship. How do we communicate when the answers aren't clear? When does communication bring clarity, and when does it add confusion? What happens when the uncertainty isn't just medical, but interpersonal? This episode has 2 parts. First, we'll explore conversations between clinicians and patients, and then we'll head into the hospital to explore how clinicians talk about uncertainty with each other. That is, if they do at all. First, meet Heather, a hospitalist and educator.
Around like 2015, 2016, maybe, my sister told me that she had started going to a high-risk breast cancer screening clinic and was like, you need to go. And I think my initial take and feeling about it was like, oh, that's just Darcy being a little over the top, anxious and paranoid, but okay, fine, I'll go.
It was a long, multidisciplinary meeting with a breast surgeon and a geneticist, both of whom she was meeting for the first time. At the end of the visit, she sat down with the surgeon.
I met with this breast surgeon, and when I meet with doctors, it's like, they know I'm a doctor. There's a little bit of like a collegial sort of aspect to the visit. And I remember her saying to me, like very matter-of-factly, oh, you could do this, you could do tamoxifen, you could get a mastectomy. And I was like, what are you talking about? Like, that was not on the menu at all in my mind, especially because I didn't even have breast cancer at that point.
According to this doctor, it boiled down to her family history.
They did genetic testing for all of like known high-risk markers, including like BRCA and a whole boatload of other genetic risk markers. And it was all negative. But she basically was like, yeah, it's negative, but you have something. We just don't know what that is yet because your family tree is just like, there's breast cancer everywhere. And the truth is, I didn't really think it seemed like that high risk a history, and I think I was falsely confident as a physician that I would know, but they were very concerned.
They recommended a mastectomy, but emphasized that it was Heather's choice. But to Heather, the risks just didn't feel clear-cut enough to justify such a big intervention from these physicians that she'd only just met.
I am foundationally an anxious person. I worry about a lot of things, and a lot of things that other people don't worry about. But at that point, I didn't even want to take tamoxifen.
So she opted for increased monitoring with regular mammograms and eventually biopsies.
It's painful to do the mammograms, and then they make you wait half naked while they're talking to the radiologist in this cold room, and then they come back and they're like, we're going to do more. And then they smash her boobs some more and it hurts some more. I kept getting results of something called lobular carcinoma in situ, or LCIS. And the thing about LCIS is that it's technically not precancer. It's more like a marker of you're very likely to get breast cancer. There's also a marker that with some types of breast cancer, it's regional. It's like, okay, if it's on the right, you're at risk for breast cancer on the right. With LCIS, it's like you're at risk for breast cancer everywhere. Doesn't matter what side the LCIS is on. And it was becoming more real because it was like every time there would be something, maybe it wasn't slam dunk cancer, but there was something that was not normal and it kept growing. I could feel that it wasn't a question of whether it would happen. It was a question of when I would decide to do it.
This whole time, the conversations Heather was having with her doctors focused exclusively on the medical risks and probabilities, and not the growing emotional uncertainty that she was feeling as these LCIS findings piled up. And then, in a routine screening, the doctors found a tiny bit of lobular carcinoma, cancer. They took it out, but the case for a mastectomy was getting stronger. She was assigned to an oncologist, who just so happened to also be a colleague of hers.
I didn't really know her very well. I didn't work directly with her a lot. And our rapport was not great, but I had one in-person visit with her. After that, all of our visits were by phone, and not necessarily by my asking for that. Like, it's very possible that she was just trying to be respectful of my time because she knew I was a busy physician as well. But I remember one time when we had a scheduled phone call visit, I was at work. I went to my office where I thought I could be private. And then, of course, she was late, which I get. I'm a doctor. But then I was in a patient room when she called me. So I had to like run out of the patient room, and I was trying to find a private place. I ended up outside of our post-op area. There's this bridge that goes from one building to the other, and it's not super busy, but it's not untraveled. So I'm out there having this conversation with her, more of the like, have you thought about the mastectomy? And I was like, yeah, I just don't want to have a mastectomy. And she just was like, well, why don't you want to have a mastectomy? I was like, what kind of question is that? Like, if she had said, yeah, I can completely understand how it would be hard to make a decision to have a mastectomy. Can we talk a little bit about your thoughts and feelings about that? What you feel like the barriers are, what you're afraid of? Like if she had elicited it in a more nuanced way about like, what is underlying this? No, I don't want to do that. It was all about the feelings.
Heather says that even at the time, she knew it wasn't logical to keep postponing the mastectomy. But she wasn't operating on a logical level. She needed someone who could help her navigate the swells of emotion the procedure was bringing up, most of which she was only able to name in hindsight.
I think that there was like aesthetics of like my body and what it felt like to be in my body. I think there was like my experience of sex and sensory pleasure. And I think another thing, like I didn't know going into the visit with the breast surgeon initially, she was like, well, we do mastectomy. And then she's like, well, some women get sensation back. And I was like, whoa, wait a second. There's no sensation? I didn't know that. So I think I was getting into the point where I was feeling a little bit like a ticking time bomb, but still having a lot of emotional pushback about making that commitment, because it's like a very permanent thing. Once you've done it, it's done.
Heather got off the phone almost in shock. She felt adrift and alone in a sea of uncertainty. So she requested to be switched to a different oncologist. From the beginning, it was like night and day.
I saw her in person. She was very thorough, very detail-oriented, had reviewed everything. First visit basically said to me, you're very high risk. And if I were you, I would have had this surgery 3 years ago. And it was like, boom, whoa, okay. Like, I will seriously think about this now. She was so direct, and she personalized it. Said, like, this is the kind of decision I would make for myself as well. I think I had already been thinking, like, okay, let's look at the options here. Either you do this, or you wait, and like, wait till when, right? Like, my worst case scenario ever was stage 4 widely metastatic breast cancer. That would be a really stupid outcome because you decided to wait to do this thing. And so I think that I was sort of in that headspace a little bit. And then she came in and was like, you should have done this 3 years ago. And I was like, all right then. And that kind of like tipped me over the edge.
She couldn't have put words to it ahead of time, but it turns out that what Heather needed was a strong recommendation. A physician who didn't treat her like a fellow professional, but like a scared patient, uncertain of the best path forward. A few months later, more than 3 years after the initial recommendation to get the mastectomy, and 3 physicians later, Heather finally found herself in the pre-op waiting area with the breast surgeon who would perform the procedure. Again, meeting her in person for the very first time.
I don't know that it was relief, there was clarity. I still didn't want to do it. I mean, when I was in the pre-op area for the mastectomy, she's like pre-opping me on the computer. And she's like, so you're ready to have this surgery? And I was like, no. She just kind of looked at me and then just went right back to her computer and kept writing. She's like, I'm just going to completely ignore that. I was like, yeah. So I was never really ready.
Heather says she doesn't hold it against her. Obviously, she was there to have the procedure, so maybe it wasn't worth engaging with. In the days after, as Heather was recovering, she grappled with her choices on her own. Had this surgery really been warranted? And then a week later, she got a call from the breast surgeon. The pathology results had come back positive for micrometastases in the breast tissue that they'd removed. So now, Heather was cancer-free, but only because of the mastectomy. It's been a little over 2 years since her last breast cancer diagnosis, and Heather says her outlook has shifted. She's made some changes to her job and more space for the things that she truly loves. One of the biggest changes, though, has been in how she talks to her own patients, especially when there's uncertainty involved.
When I make a recommendation to a patient, they're like, I'm not doing that. I'm much less reactive when I think it is the thing that they should do. And I'm much more likely to explore some more about what the barriers are. And honestly, in some cases, they just don't want to do it. I think there's some things that I used to do more cavalierly in terms making recommendations. I work at the VA. We have so many veterans who come in with vascular disease and diabetes, and they get a foot infection, and they need to have a toe amputated or half their foot or half their leg. We recommend these things all the time. But that's a huge deal. I kind of knew that cerebrally before, and now I think I feel it a little bit more about you're grieving the loss.
To learn more about different strategies physicians have in talking to patients who have to make difficult decisions, we called up April Sharp. She's a pediatric neurologist in Baltimore, and she spent a lot of time thinking about how to help families deal with uncertainty.
We talk about it in medicine, we use a shared decision-making model. We're sharing all the information and then come to a decision together. That's not really how it works. What I encounter a lot is that families have just received the scariest news that they have ever heard in their life. And sometimes it's even what for us is a more routine diagnosis. New diagnosis of epilepsy is something that I've seen make almost as many parents cry as, your child has a severe brain injury. But they've just received some big news, something that's life-changing. And then we say, okay, we've got to figure out this medication with this range of side effects, and are going to present it to you in about 30 seconds. And is that okay? It is a shared decision-making model. I've shared all the information, and then they have the information. But we have years of experience with that medication and what it looks like to have a child on it. And they just processed it in 30 or 60 seconds. I might still be processing my child had a seizure. So I think it's so important to have conversations again and again. Our care model doesn't always allow for that.
April thinks a lot about relationships. We actually first called her up because we were hoping to get her perspective on how she navigates the uncertainty in her field. Pediatric neurology is rife with ambiguity. How do you tell what a brain injury is going to mean for a child whose brain isn't even fully developed yet? In a lot of cases, April says, you can't really. But her job is still to help families understand the range of possibilities and then move forward together. She says the uncertainty in how she communicates this information and how she tries to meet families where they're at is often just as complex as the medical uncertainty she's communicating about.
I use a lot of similar language, but the conversation is different every time because they're different people and they're bringing in different things. And as they react, as they use words or language, I try to pick up on that and use it so that we are, in that moment, a team.
This isn't like a casual feel-good thing, April says. Being able to read the room and respond to families in a way that lands is critical to health outcomes, especially when the medical terrain is uncertain.
For a baby who's just born, their parents are meeting them for the first time. They look like a baby. Even a baby with brain injury looks like a baby. And so it's so important for us to meet them where they are because we're talking about therapies, we're talking about medications, lots of interventions, and I need them to buy in. I need them to be willing to come back to the appointments. And so much of it is subtle body language. Whether or not the parents are making eye contact. Is one parent looking at me and the other parent staring at the wall?
This type of uncertainty, the dance of human relationship, is not something April learned in medical school.
I developed these skills long before I ever wanted to go into medicine. I come from a poor Southern family. No one in my family ever graduated from high school. So certainly didn't go to college, didn't go to medical school. And I started very early on just observing people and trying to understand them and figure them out. My family's not very good about displaying emotions, but trying to understand, okay, this happened and these are the reactions and this is why. So I guess the other part of that is that I then went to a college that most people were from very different backgrounds than I was. And, everyone at 17, 18 is mostly trying to assimilate, and had to very quickly understand people who grew up very differently from me, talking like they talk, moving like they do when needed. And so medicine came later, but I have that approach with families.
April says that over the years, she's found that the discomfort that comes from not knowing, whether it's medical uncertainty or what's happening relationally with a family, that discomfort has actually proven to be one of her most valuable guides.
There are many things that make us uncomfortable, and those are often the things that I pay most attention to. Like, I'm thinking of another patient that I'm taking care of right now today who's had a sudden decline. I've known him for months, or he's only 4 months old, but last week he came to clinic and he did not look good. And I said, you're going to the hospital, and now we're doing potential end of life care, and things have changed so quickly. The family, they don't have all the information about why he is the way he is. And every time I walk in the room, they're in a different place. And so I show up and I support them, and we have a big conversation every time I walk in. There are some aspects of it that I've anticipated and been ready for, and others that I had to say, if you want to have that conversation right now, we will have that conversation right now. I guess one other thing that I would add, as I was thinking about this topic and with the cases that I'm currently trying to figure out, is where we create certainty from uncertainty. For example, this patient, he probably has a genetic syndrome, and I don't know what it is, and all of our tests aren't back. But what I do know is that right now, his body is shutting down, and I don't know why. And that's really frustrating to not know why, because then we don't know if it's reversible. And so what I do know is that he can't breathe, and he's relying on machines. And that is kind of the thing that I'm trying to help the family anchor on to make all the difficult decisions that they need to do. Like, that part is certain. And I think often in these really hard prognostic conversations, I find something that is more tangible to help families anchor on and say, this is certain. Many things are not, but this is. And this is how we move forward with that information. Because otherwise it would be so hard to do what we do if everything felt like it was layers of uncertainty that it is.
This brings us to part 2 of this episode. How do clinicians communicate about uncertainty to each other? We talked to a lot of clinicians for this series, and while all of them affirmed that uncertainty is a constant in their daily work, many of them also expressed discomfort around naming it explicitly. Would it make their patients or colleagues trust them less? Would it convey a lack of expertise or confidence? Would it be looked down upon? Lakshmi Santosh is one of the people out there working to change this. She's a pulmonary critical care doctor at UCSF, and I actually know her from when she was my chief resident and I was an intern. There are few people out there as earnest and committed to changing the culture of clinician communication as Lakshmi. So we knew we had to talk to her. A few years ago, Lakshmi developed a tool called the ICU Pause. Basically a tool for making uncertainty more visible in communication between clinicians. So we caught up with Lakshmi to learn more about the ICU pause and about her work to help clinicians talk more openly about their uncertainty with one another.
When I first became interested in this topic, it was a very specific case, actually, that I recall. I was a senior resident on an intensive care rotation, and there was a patient a little altered, a little confused, a little encephalopathic, who came in for what we called airway watch.
Basically, they were just going to keep an eye on him and make sure that he was able to protect his airway. In the meantime, they were also going to try and figure out what was going on.
We did a CT scan of his head. It was negative for anything big. There wasn't anything, quote, focal that prompted more detailed imaging like an MRI. There was nothing really going for infection. He, quote, wasn't that sick overall. And still, we didn't have a great explanation for this. And of course, critical care is a limited resource. And so when it was deemed that he was protecting his airway fine, he didn't need suctioning, he didn't need to be intubated, he was doing okay, we transferred him back to the regular ward team where he came from.
Just 2 days later, though, the patient was readmitted. As soon as Lakshmi heard he was back, she knew something was wrong.
And it was just this recognition and feeling of, oh my goodness, he was just here, what happened? And then that wave of, what did we miss? What did I do? What could I have done differently? Just this sinking stomach of, oh no.
The patient had continued to deteriorate, and eventually, the team on the regular ward figured out that he had an epidural abscess, an abscess that everyone until now had missed. This isn't entirely uncommon, Lakshmi says. An epidural abscess, an infected fluid collection near the spinal cord, overlaps with symptoms of many more common conditions. A standard head CT, the usual first step for altered mental status, will miss it. It's kind of invisible unless you specifically go looking for it. Lakshmi said that this patient looked like he had aged years in just the 2 days since they'd last seen him. He was intubated, he couldn't talk, and he was very frail.
What struck me in that moment was not that, oh gosh, we missed this, but was that we didn't really convey to our team when we sent this patient back that, hey, he came to us confused, and even though he's, quote, better from an intensive care perspective, we still don't really know what's going on. And so this is a case that stuck with me. And then when I became a fellow, having to choose a fellowship research project, I said, I really want to focus on this concept of uncertainty and how do we explicitly communicate that at these transitions of care, which are high-risk times.
It's really worth underlining Lakshmi's response to this case. It wasn't to double down on studying the manifestations of epidural abscesses or to try and prevent future uncertainty. Instead, it was to notice that the uncertainty they felt hadn't been adequately documented. Basically, their handoff had been incomplete.
Communication is one of the most common causes of medical error.
There's a lot of reasons for this. But in the ICU, Lakshmi says, one of the main contributing factors is the environment itself. It's a constant deluge of information.
There's alarms of all different volumes that are piercing to the ears that are all going on at the same time. Your pager's going off, the phone's going off. Meanwhile, you have a crashing patient that has an urgent airway emergency, that needs an urgent intubation, that's getting a massive transfusion protocol, that's getting 20 units of blood. You're having life and death conversations every day with multiple families, and you have to be on top of all the little details and keep the big picture in mind. As a learner, it's overwhelming. As an attending, it's overwhelming.
In an environment like this, it's easy for details to get missed. And when it comes to cases with a high degree of uncertainty, this can be doubly true.
It's kind of like a detective solving a puzzle in that you don't know if this clue is going to be important later on, the red hat or the fluid around the heart. Like sometimes we'll say, just FYI, there is a pericardial effusion, fluid around the heart. But it looks old, and it's probably been there for a while, and it's probably unrelated to everything. But just in case, if they lose their blood pressure, just remember that there is fluid around the heart. And the person listening is like, okay.
At direct odds with tracking information like this is the very real pressure in ICU medicine to keep patients moving.
You make literally tens of thousands of decisions every day in an ICU. Cognitively, you can imagine that when you get a, quote, easier admission, it's almost like, I don't want to say it's the kiss of death, but it's almost like when someone doesn't have critical care needs anymore, or doesn't have inpatient needs anymore, people's brains go to discharge mode, and it's hard to go back to the why mode.
And it's not just the cognitive load that creates this momentum toward discharge. It's also the fact that ICU medicine is a limited resource.
There's always that pressure of sick people who need those beds from the emergency room, from the operating room, from the medical floor, from other hospitals. I don't want to say there's a scarcity mindset, because there's actual scarcity. I mean, it's just scarce.
With all these pressures, ICU medicine has to be a team sport, Lakshmi says. There's no other way.
That is one of the things I love about being in the ICU, is this idea of team cognition, that we know that it's just so much information for one person, and we're actually relying on all the sets of eyes, and creating that culture too, where I want the nurse to tell me, oh, isn't it weird that they did this? Or does this look odd to you? Is this normal in this condition? I want to create a climate where, really, I say it repeatedly, like there's no dumb questions. There's no question that's too small to bother me with, because that might be the clue. You noticing something, or you asking me, is this normal in this condition, might jog something in somebody on the team's thinking to say, oh, actually, that's weird. Let's think about that differently. Let's reframe where we're at. This does not make sense.
Which brings us back to the case of the epidural abscess. Lakshmi says that one of the greatest threats in ICU medicine is premature closure. Because once someone is discharged, unless any remaining uncertainty in their case is explicitly documented, the implicit assumption is that everything's good. But so often, as was the case with the epidural abscess, the remaining uncertainty is just as vital a piece of information as the aspects of the case that are certain. For her fellowship research project, Lakshmi joined forces with a couple other doctors in Oregon and Illinois. And together, they began looking into how uncertainty was being communicated at ICUs across the country. What they found was that, at best, transfer notes were like a mini discharge summary, but they rarely, if ever, mentioned uncertainty. And in many cases, there were no transfer notes at all. So they developed a framework, what they call the ICU pause, basically a structured template for handoff notes that includes at its heart an uncertainty measure.
You just say explicitly, our working diagnosis at the time of transfer is this, though we thought about this, this, and this. And then you just select high certainty, some certainty, or marked uncertainty.
It may seem simple, but the ICU pause is already making a big impact. It's active at 21 sites, with 20 more preparing to implement it. And Lakshmi says it's already leading to fewer missed details.
And I think more interestingly, and again, hard to measure, is just that cultural piece of it's okay, even in a profession like ICU where we really talk about putting our nickel down, to use the words uncertainty and working diagnosis. Giving people the language to express that is really helpful in normalizing discussions of uncertainty and not allowing it to paralyze people, but actually enabling us to have better patient care.
Thanks for listening to The Nocturnus, Uncertainty in Medicine. Our core uncertainty team includes me, Emily Silverman, The Nocturnus head of story development, Molly Rose Williams, producer and editor Sam Osborne, and our uncertainty correspondent, Alexa Miller of Arts Practica. Our student producers are Claire Nimura and Celine Everett. Special thanks to Maggie Jackson and Paul Hahn. Our executive producer is Allie Block. Our program director is Ashley Pettit. Our original theme music was composed by Ashton Spencer, and additional music came from Blue Dot Sessions. Artwork for Uncertainty in Medicine was created by Eleni Debo, who is represented by Folio Illustration and Animation Agency. The Nocturnist Uncertainty in Medicine was made possible by generous support from the ABIM Foundation, the Gordon and Betty Moore Foundation, and the Josiah Macy Jr. Foundation. The Nocturnist title sponsor is the California Medical Association, a physician-led organization that works to keep the doctor-patient relationship at the heart of medicine. To learn more, visit cmadocs.org. The Nocturnist is also made possible by support from listeners like you. In fact, we recently moved over to Substack, which makes it easier than ever to support our work directly. By joining us for a monthly or annual membership, you'll become an essential part of our creative community. If you enjoy the show, consider signing up today at thenocturnist.substack.com. If you enjoy this episode, please share with a friend or colleague, post on social media, and help others find us by giving us a rating and review in your favorite podcast app. I'm your host, Emily Silverman. See you next week.